So today's topic is antimicrobial stewardship. Those who have the textbook, page number 166 onwards. If anyone is joining late, please help them out with the page numbers. So antibiotic resistance, it's a global challenge now. Okay, it's seen that by 2050, okay, we will see around 10 million deaths because of antibiotic resistance, and it will cost up to 66 trillion pound, okay, to combat this issue of antibiotic resistance. So it's a very expensive pandemic that we are looking towards to, okay, if we are not able to successfully join hands and do the antibiotic stewardship. So antibiotic resistance policy or antimicrobial policy. So microbiology department of a certain area will create an antibiogram. Okay, antibiogram is a table that contains name of specific bacteria and which class of antibiotic can tackle this bacteria without jumping into some high-end antibiotics. Okay, you don't need uh, higher class antibiotics to tackle narrow spectrum bacteria. Okay, so spectrum of the bacteria, name of the bacteria, species of them, and which class of antibiotic can successfully tackle this infection is that is the antibiogram. Okay, so that has to be distributed to the hospitals, and hospitals have to follow this. Okay, so antibiotic susceptibility profile may also be analyzed regularly. Okay, and the common resistance patterns seen in a hospital of a specific bacterial isolates should also be reported. Okay, so the hospital should know which particular bacteria is causing the major in infections. Okay, hospital acquired infections, which is the most common causative agent causing these infections. Okay, so this report has to be submitted to the hospital infection control meetings. So policy should be prepared in consultation with respective clinical departments. Okay, so there may be certain bacteria prevalent in one department, not seen in another department. So every department, every clinical department should submit their own reports on antibiotic activities, antibiogram, okay, bacteriological isolates, etc. So this is an antibiogram. How you use an antibiogram. Patient's sample will be taken. It could be urine sample, blood samples, sputum, swabs. Okay, this all comes under patient sample. It will be taken for testing. Okay, so sample culture will be grown in a day. Antibiotic disc will be added. After 24 to 48 hours, you will understand which are the specific bacteria that are growing in these petri dishes. Okay, and then based on the bacterial growth that you see, there are tables which tell you in detail about what dose of antibiotic should be given. Okay, what is the type of bacteria here? Is it resistant bacteria, intermediate, or dependent on dose? Okay, it's a what is the quality of the bacteria here that can be analyzed, and accordingly an antibiotic can be prescribed from the antibiogram. So that's how antibiogram is used. So coming to the antibiotic policies and principles, data is analyzed on a quarterly basis as per hospital records. Every 4 months, data is analyzed on what are the common bacteria that are causing infections, okay, which are the common sites that are causing infection, age group, which age group is commonly most commonly affected in the hospital, okay, patients located in which area, outdoor patient or indoor patient, ward patient or critical care patients, which ward patients are affected a lot because of uh, hospital acquired infections, that also you have to study, okay. And antibiogram data also is taken from the site of infection, age group, patient location, okay. If there is any resistant organisms that you have seen for the first time, okay, that is unusual, it has to be informed immediately to the hospital infection control departments. Then standard treatment guidelines as per age. What guidelines you will use for a small baby, okay, neonate. The antibiotic treatment guidelines that you will use for a neonate is different from a pediatric patient, different from an adult patient, okay. So as per age, your treatment guidelines changes, okay. Depending on community acquired infection, healthcare acquired infection, guidelines are different, okay. From where did you get this infection? From home, back from home, or from a hospital, okay. So treatment guidelines slightly vary, okay. So treatment guidelines have to be implied depending on the age, source of infection, etc. Classification of antimicrobials into first line, second line, and reserve group of drugs. So why you have to classify the antibiotics? So that you don't abuse the antibiotics, okay. So first line of antibiotics that we use should tackle narrow spectrum bacteria. Second line for broad spectrum, and reserve group of drugs should be used for resistant bacteria, like that, okay. Don't use reserve group of drugs or high class antibiotics to tackle small infections, okay. So that is how you have to classify antimicrobials and use them accordingly. Prescription auditing has to be done. That is, you do the surveillance of antibiograms that you use in the hospital and how the doctors are prescribing. Okay, are the doctors making use of the antibiograms? Okay, are they prescribing wrong antibiotics for the wrong patient or not? Okay, so that all comes under prescription auditing. Then education and training of all infection control activities in collaboration with hospital infection control committee. Okay, they continuously you have to train all the practitioners, especially all those who come in contact with the patient, give care to the patient, give medicines to the patient. Okay, all clinical practitioners should continue their education and training in antimicrobial policies. And this training should be conducted by the infection control committee. Measures to control the spread of antibiotic resistance. So this is a multidisciplinary approach. Okay, it's not the task of just one department. Every department should join hands towards this to use the local antibiogram and stick to it. Okay, and you should be justifying the use of antibiotics. Don't use antibiotics randomly. Only when there is a justification for the use of antibiotics, it has to be used. Initiate antibiotic treatment only when you know you're sure that this is a bacterial infection. Don't use antibiotics for other infections, viral infections, and everything. Okay, patient sensitivity, tolerance, etc., should be assessed. For narrow spectrum bacterial infections, appropriate dosage and appropriate antibiotics should be used. And you can do a cyclical rotation of antibiotics within the class. Class 1 antibiotics may have 3 or 4 options. Okay. Class 2 may have 3 or 4 options. Within the class, if you want to change the antibiotic, stay within the class. Don't jump the class. Okay. For first 5 days, you used class 1 antibiotics. For the next 5 days, you're using class 2 antibiotics. Don't do that. Okay. If you want to change the antibiotic, remain in the same class of antibiotics. Don't jump the classes. Don't go to the higher classes. Okay, so do the cyclical rotation within the same class of antibiotics. As soon as the infections subside, you have to discontinue the therapy. Periodically, you have to do prescription audit. Pharmacy auditing also has to be done. Okay, so these are the measures to control the spread of antibiotic resistance. Then standard precautions, contact precautions using gloves, PPE, okay, hand hygiene, adherence to hand hygiene, PPE. Excuse me, all this has to be practiced. Strictly, it has to be practiced. A lot of infections can be prevented just by doing hand hygiene and wearing PPE. A lot of infections can be prevented. Then MRSA, methicillin-resistant Staphylococcus aureus infection. Resistance, it is resistant to penicillins, cephalosporins, occasionally sensitive to vancomycin, teicoplanin. Okay. So methicillin resistance means penicillins cannot work on it. Cephalosporins also will not work on this infection. And this is a highly transmissible infection, and even it can cross hospitals. Control measures of MRSA. Screening of MRSA carriage. Every infected patient should be screened for MRSA before admission. And if it is MRSA positive patient or MRSA positive carrier, you have to admit them in isolation ward. Standard and contact precautions has to be used for MRSA prevention. Isolation has to be followed if it is diagnosed, confirmed that this is a MRSA case or a MRSA carrier. You have to confirmly, positively do the isolation. Treatment of infected patients has to be done. All the MRSA cases can be kept together if you run out of isolation rooms. Environmental cleaning has to be done after you discharge them. Fumigation, fogging has to be done for the ward. Education and training of staff is also important here. Training and education of staff is usually about antibiotic resistance, importance of hand hygiene, using glutaraldehyde wipes and all, chlorhexidine wipes, all wipes, isolation policy. Okay, these all are the basics of education and training of staff when it comes to MRSA infections. This is the MRSA screening. You can see as soon as a patient arrives, if it is a high-risk patient, immediately you have to do the MRSA screening. Okay, if it is positive, isolation has to be done. Negative, you can put them in general wards. Even if it is not a high-risk patient, still culture screening can include MRSA test. If it is MRSA positive, definitely isolation has to be done. If it is negative, no action has to be taken. Then we have VRE, vancomycin-resistant enterococcus infection, another resistant infection, difficult to treat because of intrinsic resistance to many antimicrobial agents. Intrinsically, because it affects the intestine. Within the intestine, it resists a lot of antimicrobial agents. Okay, so it's very difficult to treat. Control measures, you have to be very judicious with the use of antibiotics. Judicious means don't abuse the antibiotics. Use it only and only when it is required. Education of healthcare workers about the judicious use of antibiotics, hand hygiene, contact prevention, because VRE is a contact transmission infection. Okay, fecal route usually it is used to spread. Okay, so hand hygiene, contact transmission precautions should be focused more on. Hospital infection control practices, you have to be very strict with this. Equipment and environmental cleaning, general patient care equipment should not be mixed up with vancomycin resistant infection patient. Okay, you have to keep specific equipments for this patient. Don't use the equipments you use on a VRE patient on other patients, because through indirect contact, infection will spread. Single-use equipment for patient care, you have to stress on this. Isolation, it is definite. Separate toilets. Toilets should not be same for VRE patients and general patients. Use of personal protective equipments, gloves, mask, gowns. surveillance has to be done, which is each and every cases should be reported to the Hospital Infection Control Committee. Then multi-drug resistant gram-negative bacteria like ESBLs, plasmid-mediated AMPC, okay, carbapenemasi. These are the drug resistant gram-negative bacteria. So screening the patient, okay, how do you find out these infection? All high-risk patients, people who are admitted in a ICU for a long period of time, patients who are on antibiotics for a long period of time, okay, more than 2 weeks, a patient is on antibiotic, okay, a patient is in a critical care unit or a high risk unit for more than 2 weeks, severely ill patients, chronic disease patients, okay, presence of any invasive medical devices like uh, ventilator, central line. Okay, these devices are present in the patient's body for a long time. Okay, these all are high-risk patients. All of them has to be screened for multi-drug resistant gram-negative bacteria. Swabs can be taken from multiple sites: throat, nose, okay, perineal region, skin. You have to follow strict hand hygiene methods here. Contact precautions should be followed. Okay, if it is diagnosed, confirm that this is a multi-drug resistant gram-negative bacterial infection. Isolation should be forwarded and cleaning should be done. Dedicated patient equipment. Do not mix the patient's equipment with any other patient. Okay, don't mix the use of it. Again, judicious use of antibiotics. Prescribe the antibiotics only that can work. Okay, don't jump the classes. In healthcare facilities, antibiotics, which are of some high classes, are used for small fevers and infections. So that's the reason why in healthcare facilities, antibiotic resistance have emerged. You have to isolate the patients who are infected. There is a need for more expensive and broader spectrum antibiotics in the future to treat more rising infections. Not using the antibiotics judiciously in today's present world will pose a threat in the future of the patients. And in the community also, it is very hard to track the pharmacies who are giving antibiotics without prescription. In India, if you see, if you go to any medical store and ask for an antibiotic without prescription, you will get it. Okay, that should not be the case. Without prescription, no pharmacy should be selling antibiotics. This is the reason why in community we are seeing antibiotic resistant infections more and more. Okay, so there should be strict laws against it to control the sale of antibiotics. Okay, so antibiotic treatment for hospital. If prescriptions of high risk antibiotics, if you reduce the prescription by 30% in hospital, we can reduce antibiotic resistant infections in the future by 26%. Okay, just by reducing the prescription rate of antibiotics, you can reduce the antibiotic resistant infection in the future. Okay, so antibiotic stewardship. What is stewardship? This is an effort to measure and improve how antibiotics are prescribed by clinicians and used by patients. This is the definition of antibiotic stewardship. Okay, you are measuring how antibiotics are prescribed, keeping a track on it, and improving how antibiotics are prescribed by the clinicians. But clinicians may be doing their work properly, but if the patients are abusing it or misusing it, that is also a problem. So it's the joint effort of patients and clinicians to follow antibiotic stewardship. So antibiotic stewardship, it aims to optimize antimicrobial use among patients in order to reduce antibiotic resistance, improve patient outcomes, and safety and ensure cost-effective therapy. Okay, so these are the aims for antibiotic stewardship. The main aim is to reduce the resistant infections. And even if there is resistant infection, it should not lead to mortality. Steps of antibiotic stewardship. You have to implement an antibiotic stewardship program with the help of infection control committees. Continuously monitoring and analysis of each resistant cases. Okay, keeping a surveillance on. And then other requirements of antibiotic stewardship, it's very easy. Okay, if first you have to enhance your current practices of infection control and prevention. Okay, whatever infection control and prevention is universal. Okay, you are supposed to follow it, but some hospitals or healthcare facilities still lack, okay, basic infection control and prevention methods. They are not that strict with it. You have to enhance it. Okay, become more strict and more vigilant with the infection control and prevention practices. Control the source of infection, whatever source it could be. Okay, point one source or common source infection. Okay, whatever is the source of infection, you have to control it. Okay, even if it is medical devices, you have to control it. Prescribing antibiotics only when they are needed, not for viral fever, not for fungal infections, not for parasitic infections. Okay, only when it is a bacterial infection, prescribe antibiotics. Prescribing appropriate antibiotic with adequate doses. Dosage is important. How long you will give them antibiotics, okay, and what dose of antibiotics, okay. So that the doctor has to take care of it. Using shortest duration antibiotics based on evidence. Ideally, it is 5 days, not more than 5 days. Okay, 5 days of antibiotic is ideally what we practice. Reassessing treatment when culture results are available means for 5 days you have prescribed antibiotic. Day one, you have taken a culture from the patient's body. Okay, based on that culture results, antibiotic was prescribed. Day three, again a culture result came, and a second culture result came, and now it is a different bacteria. Okay, again you have to change the antibiotic based on the change in bacteria. Supporting surveillance of antimicrobial resistance and hospital acquired infection. Okay, they go hand in hand. Okay, monitoring antibiotic consumption as well. How many patients are right now prescribed on antibiotics? How many of them are taking it on time? Okay, is there any missed doses? This all comes under the surveillance. Educating the staff continuously. Okay, as a part of their CME or CNE, continuous medical education or continuous nursing education. Continuously training your staff, new staff, existing staff. Okay, once a year or twice a year, a topic on antibiotic stewardship or resistance training should be given. Supporting an interdisciplinary approach. This is not just the task of the microbiology department alone. All the clinical departments where patient care is given, okay, it is their responsibility as well. Okay.